Good morning. So welcome to session number, whatever number it is, which will be repeated later at some other time with a different number. I'm Michael Partington. I'm one of the pediatric neurosurgeons in town, and I am presenting the first few minutes of this talk on headaches. And the bulk of it is going to be done by the excellent Dr. Janicek, who is going to wave to the people. Dr. Janicek, there you go. And afterwards, we will have some opportunity for questions. I'm doing several jobs today, so that I'm going to be doing part of it and then running away. Don't take it personally. He is going to be answering questions. And I thought I saw in the room, there she is. Dr. Song is one of my partners. We have another neurosurgeon available to answer questions that Dr. Janicek doesn't have. So, could you, are you advancing slides or am I? We, as always, have to thank our various sponsors. And this full title, Headache, Chronic Pain, and Hydrocephalus, Perspectives, keyword of a neurosurgeon and a neurologist. So what I want to do is, so when we're talking about someone who has headaches in the context of a shunt, sometimes we're going to wind up saying, you have a shunt, you have headaches. These two things are true, and unrelated in the parlance of our times. And that I want to be able to get to that point. So I want to start with a little bit on, so what am I thinking through, and then what prompts me to say, I think you should meet Dr. Janicek or someone just like him. So my issue then, if we start with a new and persisting headache. So I'm not talking about, the anvil fell on your head like happens in, Roadrunner cartoons all the time, and you have a headache after that. I expect that. We're not talking about, I know I have sinusitis and I have some headache associated with that. We're talking about the ongoing headache. So my first question and first thing that we will run through is, have you had a malfunction before? And if the answer is no, this becomes more complicated, because then we have to be able to consider, prove, and either include or exclude the diagnosis of shunt malfunction. If the answer is yes, we wind up using that information because, not because we're big fans of someone having lots of malfunctions, but because we understand what the patterns are and what we're going to be thinking about. So we can use the experience from that and settle the shunt question. And you'll notice that at some level, I'm saying if you have or if you haven't, and I'll include, well, there was a malfunction, but it was when, Bobby Sue was 3 months old and they noticed her head was bigger. Okay, not that one, because now that Bobby Sue is 13 years old, that story won't necessarily be the case. So we have to, if you have one revision in early infancy, I wouldn't count that one. Where I'm going to go, I'm first doing whatever it is that we do to evaluate a shunt. That's a whole separate talk beyond the scope of this one. But let's assume that we've got to the point where by whatever means we know the shunt is working. This is not where we have the conversation. Do you mean an MRI? Do you always get a CT? What's a shunt series worth? Are you tapping the shunt? Do you need to measure pressure? Have you done, no, let's assume we know it's working. First thing is look for an acute but treatable cause. I said persisting headaches, but migraines have to start at some point, and they do not necessarily show up, the first day of life and stay with you. In fact, they're more likely to be related to other opportunities and times during growth and changing hormonal environments and things like that. Sinusitis and allergies is a huge overlap. Sinusitis is a word we use a lot. There are some people who have a bacterial infection of the sinuses, aka sinusitis. That's not the same person as someone who has sinusitis in the context of a viral infection, respiratory. That's not the same person as the one who has seasonal allergies with prominent involvement of their sinuses. It's not the same person as one with asthma who has sinus symptoms as well with asthma exacerbations. So sinusitis allergies is sort of a triangle of things or overlap that we talk about, the ENT folks talk about, the pulmonologists talk about, the neurologists talk about, and we will have things there that can be addressed and can be treatable causes. But that's one of those things that we would put on this list. I will always mention remote infection, and especially in things like spina bifida patient who has a urinary tract infection. For some people with no sensation, shunted hydrocephalus, non-ambulatory bladder infection, oddly enough, some of them will show up with a headache. You can all immediately ask me, how does that happen? And I'll say, I have no idea. We just don't, so please don't ask. I also mentioned constipation. I went into neurosurgery school specifically to avoid becoming a general surgeon, and yet I talk about poop multiple times per week. And the reason is just be aware of the relationship. A shunt, let's call it a simple shunt. I've got a catheter in the ventricle, a valve, not even a fancy one, but a valve that opens at a certain pressure difference across it, and a tube from there down to the abdomen. The valve is not smart. It doesn't know what you're doing. All it does is if the gradient across it, let's say if the pressure in your head is 10 centimeters of water higher than whatever the pressure below is, it will open and then close. Great. Your abdomen typically lives at around atmospheric pressure. We're all standing in the atmosphere. We all have abdomens. Mine's bigger than Dr. Janicek's, but neither one of us has one that routinely explodes because it's way higher than atmospheric pressure, or collapses because it's very negative to atmospheric pressure. We just sit there. So typically, getting past 10 will open that valve. When your head gets to 11, it'll open. If you have a lot of poop and gas and pressure in the abdomen, that is resistance. That's added on. One side of the valve is now at plus 20. And then your head, well, when's the valve going to open? Not until it gets to plus 20 and plus 10, 30 centimeters of water. So you can have quite the headache. It's still a functioning shunt. It will open at the higher pressure. It probably won't kill you. But people with constipation show up fairly frequently. Again, think of the ones with neurogenic bowel. So our Gillette-based practice like mine in town, but true in other places, probably, the spina bifida patients and the cerebral palsy patients with neurogenic bowel are the two big ones. But anyone can become constipated under the right circumstances. If we still can't exclude shunt malfunction and we haven't got one of those other things going on, we have some tools. So I'd think about repeating the imaging. These headaches have been going on for 2 months now. Things change. It might be worth doing it if you're someone whose imaging changes. It might be worth, at that point, using one of the forms of flow studies. So the imaging one is a radioisotope flow study. You put a radioisotope tracer, a radioactive dye, basically, into the shunt and get images of it arriving at the abdomen. You can also do that. There is a device now coming, it's on the market, it's now FDA approved, et cetera, called the shunt check, which basically does the same concept non-invasively, cooling the skin above a little, basically electric thermometer, digital thermometer. What it does is as coolness goes under the sensor, it implies that it's moving because of flow. So in a non-flowing system, the skin temperature wouldn't change if you have the cooler, the ice cube in the original version of their study. Now it's one of those little chemical packs that you use for an ice pack in first aid kits. So if the coolness doesn't get there, it's not flowing. If coolness does get there, it is flowing. Not flowing is still a problem, though. Why do we repeat studies and things like that? Well, because shunts don't flow all the time. If your pressure is low enough, the valve should shut. You will intermittently have nothing coming out. So this is one of those times for considering flow studies, which are not a terribly sensitive or specific test. They are just one of the options. We will also consider intracranial pressure monitoring. The subtlety of, I've had headaches that occur daily, and yet I can't figure out if it relates to the shunt. Well, at least measure pressure. Pressure in your head is not a measurement of function. It just gives us an idea of the pattern. So if I have pressure that's very nicely behaved and my headache starts and nothing happens, my headache stops and nothing happens, they're not related. So this is probably not a pressure-related headache and therefore probably not related to the shunt. If you have the normal human variation, like my pressure is higher when I'm asleep and dreaming. True of everybody in this room. Your brain is very busy when you're dreaming, and it metabolizes a lot and uses a lot of oxygen, and it's a little bit bigger, got more blood flow in it, so the pressure goes up. Frightening thing is that apparently that's the busiest time in my brain's life is when I'm dreaming. So I can operate on Steve's brain when my brain is idling, but apparently my brain when sleeping is very busy, and I don't know what my dreams are about. That's why that scares me. what's so darn important, and I can't remember it. But I can poke Dr. Janicek's brain in the OR and go, do. So your brain is idling for a lot of the things we do, drive on freeways, land aircraft, whatever. So ICP monitoring is something that, it could be the normal physiologic, normal human variation. You might be able to match it to symptoms, you might not, but that's another one of my tools there. And then ultimately, if you ask the question, what's the gold standard for testing a shunt? The correct answer, I think, is there isn't one, but probably taking it apart is the best or the closest we get to that. Are there people with subtle shunt stuff problems who will still have an okay shunt exploration? Yes. So that's why it's not an absolute 100% gold standard. But those are sort of my options and my initial perspective on a changing headache story. So then this is a point where if I've done all of those things, I will start to involve my colleagues if we have a story where that headache is persisting, it's becoming daily, it's not progressive. Shunt-related headaches things get worse over time in general as a shunt declines in its ability to function, you get more symptomatic. So if we get to a steady state where this is just going on and you're not getting any worse in other measures, then that's the point where we start shifting over to thinking about daily, non-progressive, no other objective findings. That's where I would start to think about the neurologist. The other referral that I do, I'm happy to look at the back of the eyes of anyone I see, but a dilated eye exam, which I don't do, but the ophthalmologist will do. The eyeballs are an outgrowth of the brain, and so by definition, since they have a convenient window on the front of them, they're the only place where you can look at the brain. So both to see is the optic nerve swollen. A swollen, puffy optic nerve in general relates to increased pressure behind it, some degree of swelling in the brain or spinal fluid pathways. The second is that you can also look at the back of the retina where you see the arteries that supply that, the veins that draw them. And in a lucky few, you can always see the pulse in an artery because it's got your blood pressure behind it, but some people have a venous pulse. The vein itself also pulses. If you have spontaneous venous pulsations, the pressure in your head has to be normal. And this works out from the math of where does venous blood go and what is the intracranial pressure, et cetera. So if you see spontaneous venous pulsations, that's even better. So no swelling of the optic nerve, and you have spontaneous venous pulses, great. You don't have high pressure. Similar in sensitivity as a test goes to measuring pressure with a monitor. So that's not a bad test. I said if you're lucky, because what proportion of normal humans have spontaneous venous pulse is not 100%. It's probably around, and I usually say about 40%, and Dr. Janicek may have a different number, and someone down the hall may have a third one, but it's not all of us. So if you see it, great. If you don't see it, it has no meaning. But if my ophthalmologist and those other steps don't help me, then I'm fairly sure that this is the last slide before we shift to, yes. So then Dr. Janicek is going to come up next while we change over the slides, and unless they're not here, right? Okay, so then we're swatching to a second one, and he'll continue from there, okay? Are there any really quick burning questions before we let him wander up and while the slides are changing over? Excellent. Does that mean I answered everything? We can all go have lunch? No, it doesn't. I introduce you, Dr. Steve Janicek.
It's removable. That's dangerous. Hi. Thanks for coming. The question becomes after somebody like Dr. Partington determines that it's probably not the shunt, but if you still have headaches, what can it be if it's not the shunt? Oh, a word for our sponsors. Okay. It is normal to have headaches. Unfortunately, if you happen to have a shunt, the first thought is that there must be something wrong with the shunt, and it's a huge disadvantage to have a shunt because of that phenomena. I mean, and that you're immediately, your brain gets activated by the fact that it could be the shunt. And so we're in that situation with a number of patients. Sometimes somebody will have a headache, and we get an MRI scan, and there's a small mass, and it's probably benign, but it could grow. It's not causing the headache. It's not in the right location. It doesn't cause any mass effect. But every time the person gets a headache, what's their first thought? Oh, that's growing. I mean, and it really is hard to. It creates a management issue because, understandably. There are different kinds of headaches. There are intermittent headaches, which usually there are intermittent headaches, there are constant headaches, and then there is a mixed headache disorder where people have a constant sense of pain that they can't turn off with acute exacerbations over time. For intermittent headache, most intermittent headaches are migraine. The migraine pattern is, most people think in general language that migraine means a really, really bad headache. You can have mild migraine, so it has nothing to do with the severity. Migraine is a mechanism of headache, and it has to do with a spreading wave of electrical depression over the brain and then blood vessel changes in caliber. And there's nerve endings on the medium-sized blood vessels of the brain which are actually, which convey pain to your pain centers in the brain. And that is a migraine. Migraine usually has a pattern, not always, of when you're winding down. So I always think of migraine as when you're coming out of battle, after a long day, at the end of the day, after lunch, they're almost always relieved, at least mostly, by sleep. Whereas pressure headaches are worse after you're in a recumbent position. Migraine is almost always relieved by sleep. There's muscle contraction headaches. Muscle contraction has a different pattern. Usually muscle contraction is in anticipation of activity, in anticipation of a demand, either physical, like going into battle, emotional, intellectual, going to school, and they peak throughout the demands of the day because our muscles tighten up in response to that phenomena. The brain doesn't have any sensation except for those medium-sized blood vessels. So you can poke somebody in the brain. Dr. Partington does it all the time, and that doesn't hurt. I don't do it in my office generally. But the muscles can hurt, the medium-sized blood vessels, and then the sinuses can hurt. The concern, of course, with intermittent headaches is, are you having intermittent increased intracranial pressure with intermittent shunt malfunction? It's a real bugaboo. It's rare, but it does occur, so it's always in the back of our minds as we're evaluating people with intermittent headaches in a shunt. The biggest problem, what this talk is supposed to be about, are continuous and mixed headache disorders. A continuous headache is almost always has a muscle contraction component. Where the muscles are tight, people experience a band-like sensation around their head, or it can be more localized to the frontal, temporal, or occipital muscles. Some people feel pain over the top of their head or the vertex because of the pulling down of the muscles. Most people with muscle contraction headaches, especially continuous muscle contraction headache, have tight knotted muscles in their neck, in their trapezius musculature, and those muscles are linked. They're all involuntary. You can't tell somebody to loosen up their temporalis muscle to make their headache go away. You can have plus or minus migraine, which would make it a mixed headache disorder. A lot of people start off with migraine, and then it becomes continuous. There is a designation, unfortunately, called chronic daily migraine, which is, I believe, a misnomer because chronic daily headache is never a vascular headache like a migraine, but it can have migraines on top of it, and it can start with migraine. And then there's, when you have a continuous headache, the concern is pressure, and that's why Dr. Partington or neurosurgeons, neurologists look at that and say, does the person have, in my office, I try to see spontaneous venous pulsations. I think it's a little north of 40%, but it's certainly not 100%. If I can see that, I know that there isn't increased pressure as a cause of headache. And then infection or inflammation, as Dr. Partington was talking about, sinus infection, an infected shunt, meningitis, those sorts of inflammatory conditions can produce a continuous headache, usually, again, with other stark signs that distinguish it from a muscle contraction or a migraine headache or shunt malfunction. And then there's this thing that I'd like to talk about that is that my patients have informed me of over time. It's amazing, you can learn something from patients if you listen. I've taken care of a lot of people who've had chronic pain conditions, and most of those folks have some degree of what I, for want of a better term, call central pain sensitization. And I'll talk about that a little bit. First of all, I thought that this was just a catchy caption. I'll try to tie those together. Brains, boats, shunts, and mosquitoes. The sensory experience in general, we assume that our sensory experience is pretty objective. It objectively measures what's going on out in the world. But it's really modifiable by multiple factors. And if you've ever been in Minnesota and gotten bit by a mosquito, and I know that's a rare experience, it can be the only mosquito in the county, and I get bit in my left shoulder, and my entire body starts itching and crawling. And 10 minutes ago, I'm in the most comfortable environment, and all of a sudden I have to go inside because I'm itching and crawling all over. And what's going on there? What's going on is the mosquito acts as a threat. It turns up the gain in my sensory, in my brain, looking for other mosquitoes. And the normal traffic that is coming up through my body gets reinterpreted by the central itch and crawl mechanism. If you ever want to have a good time and you have a terrible morbid sense of humor, go to a talk on head lice and watch the crowd itch their heads. Okay? I mean, if you think, that gives you a good example of what's, I can even mention it, you don't have to see a picture and right? And so we can create sensory experience, and this doesn't have to do with pain, but it's related and by suggestion. And this is not a psychological phenomenon. This is how the brain works and processes information and tells us what's going on in the world. And so it's really important. There's a phenomenon called disembarkment syndrome, when people get off of a boat and they're still rocking. Okay, and so the rocking of the boat sets up an expectation in the brain. It sets up a pattern, and it comes back. And some people, if it's most of us have that experience where we're sitting an hour later and our chair rocks to the side, and it's just random and nothing. There's nothing that caused it. It's not drama. I'm not making it up. My brain has a program that can go off automatically after it's been set up, and so. It is interesting, and it does relate to our pain and our pain perception and our pain experience. So many people with chronic pain get invalidated because we cannot see pain. And, oh, you don't look like you hurt. And people, I've in the hundreds and hundreds of kids that I've seen, and I mostly see kids, but a lot of this applies to adults. Some of it will be specific to school-age children. I've only had maybe one or two who are making it up for attention, but that's everybody's perception. You go to somebody, and so people with chronic pain are constantly invalidated by practitioners, by their coworkers, by their school principal, and they just don't understand the patient's experience. This is not made up, and it's not psychological. It is simply how the brain works. And so the thing that's particular to pain is that pain does affect all aspects of function, especially chronic pain. It affects sleep, it affects mood, it affects activity level. Pain is invisible, so you can't see it. The interesting thing, when I see people who are clearly getting better in their function, we don't get used to pain. People will say, it's the same, but I'm getting used to it. And we can get used to bright lights, we can get used to loud noises. We're supposed to, so we can make sense of the world, but pain has a different function. Pain is to avoid injury. And so your brain will not let you get used to pain to the point where you will break a leg, because that doesn't help us survive. And so, in fact, pain goes the opposite direction. Instead of a bright light, me getting gradually used to a bright light or a loud noise, it goes the other direction. It becomes more and more intense because the brain wants us to do something about it to stop it. And when pain becomes pathological, when it becomes chronic, we can't do anything. But the brain keeps saying, do something, do something. And so it turns up the pain perception rather than turning it down with time. The other thing is we can't relive physical pain like we can relive the other senses. I can close my eyes and see a beautiful mountain scene in my mind. I can play music in my head and kind of hear the music, and if I hear it on a radio or something, no, that's not the version I was listening to in my head. I mean, you can compare, but when you try to think about a physically painful experience you've had, try to relive that in the same way you relive music or relive a visual sensation. You just can't. The brain wants you to just experience pain, avoid that forever, and move on. And you don't compare the quality. So when we ask people, what is it? Oh, it's a 7.3 now. There's so many factors that make that a bad scale. I mean, you just can't do it that way. Whoops, getting ahead. So because of that, when people recover from chronic pain, and I've seen a number of people recover from chronic pain, their function improves, but their report of pain will be the same, and it misleads us because, oh, that's not working, we have to try something else. And you just have to have, I think I'm in an advantage position because I have parents who can independently observe how the child is doing, and they will say, yeah, he's back on the football team, he's hanging out with the friends more, he's more active, he looks a lot better, but the kid's still reporting a high degree of pain. Because if you have pain 24/7, and the first step of recovery is to reduce the pain level before it breaks up, the kid doesn't notice, and I say the kid because that's all I take care of with kids. The kid doesn't notice until they have pain-free intervals, and usually it happens in the evening when they get a headache and oh, here it is, and then they say, wait a minute, this is new. I don't think I had pain this afternoon. And then it rapidly melts away after you get these pain-free intervals, if you have a continuous pain issue. So when you're asking somebody, and I remember an experience, this football player who was really laid up with chronic daily headache, and out of school, off the team, not interacting with anybody. His mood was shot, his sleep was shot, everything. And he looked better when I saw him back, and he said, oh, it's about the same. His mom almost strangled him. She said, are you kidding me? How can you? And I see that experience a lot. And that's a situation where you can't invalidate your kid's experience. His experience was it hadn't changed much. I used to hurt all the time, still hurt all the time. But you're on the right track when function improves, and function almost always precedes the experience of pain. As I mentioned, we can't relive physical pain, and this affects pain recall in comparison. So you have to have an independent observer, in my experience, to get better. So the brain gives you the sensory pain experience, and you need a sensory nerve to transmit that pain to the brain. There are many ways in which that can happen. Pressure, in the case of a malfunctioning shunt. You can have an injury, and we don't think of it, but surgery is an injury. I mean, you're breaching somebody's skull, or it's kind of like banging your head on the ground. A migraine, an infection, inflammation, or muscle contraction all produce nerve pain discharges that go through the nerve and give us the central brain pain experience. What happens is, with a central brain experience, is muscles tighten up, and there's the laser. Look, muscles, and so pain causes us to tighten up. And sometimes that happens to the extent where the muscles actually produce the pain experience, and you don't need to have a migraine, infection, inflammation. And this is a cycle that keeps itself going. Then you add on top of that the effect of pain on all these other factors. Pain affects our activity level. If you hurt, you're less active naturally. And if you're less active, your endorphin levels drop. Those are natural painkillers. And your pain experience is enhanced. If you're in pain and can't sleep, and many people with a chronic pain tendency have a preceding history of having difficulty falling asleep anyway, but if it further disrupts your sleep, if you're sleep deprived, your pain experience is enhanced. The pain centers in the brain are tied to the limbic system, which is the center of emotion. That's why I swear when I stub my toe. I swear sometimes when I don't stub my toe, but just not as frequently. And certainly your mood, which is influenced by pain. If you're in chronic pain, we don't address mood right away, but you'll have to eventually if it's long enough, because it really drags your, obviously, it's hard to be light and cheery when you're in pain. Then you can take away the initial inciting events that cause the pain in the first place. And you see that we have a number of interlocking cycles that can maintain chronic pain. And that's why it was the shunt, and so it has to be the shunt now, might not be true. It was the shunt that started this ball rolling. But once it's rolling, all these factors come into play, and they have to be addressed separately, and I think that we're very poor at doing that. Then if you have stress, and none of us do, but those people who might have some stress, stress enhances muscle tension for sure. Stress deteriorates mood, and so that can become an further inflammatory factor. And then in my population, if pain keeps you from attending school, you sleep in, and you wake up at noon, and then you try to get to bed, and you don't get to bed till 3 in the morning, and your mom wakes you up in the morning saying, "Honey, do you feel better?" And you just got to sleep, and so you don't feel better. So that's a pathway that enhances the sleep dysfunction. And then also, if you miss enough school, you get behind. That's a stressor. The authority figures start to get after you and telling you that you're going to fail. That's a stressor. And you get invalidated. And so all those things can occur. And this is something that I see in my office probably 3 times a day during the school year, this pattern. And most of those patients do not. Some of those patients have hydrocephalus in a shunt. Some people have a concussion. Some people have a preceding history of migraine. Some people have a non-concussive injury. Some people started off with an infection or inflammatory process, but they all seem to fit this pattern and all tend to respond to the same measures. Now, when we talk about treatment, well, first of all, then you're constantly monitoring, though, especially if you have a shunt. Are we sure it's not a pressure thing? Is that intermittent? Are we sure, are there further injuries? Is there migraine that we have to address separately, infections, inflammations, and that kind of thing? And so that's the full-blown picture. As far as treatment goes, there's a 3-pronged approach in school-age children anyway, and one is a medication strategy, second is a non-medication strategy, and the third is a school strategy. And the medication strategy, there are medications that are pretty good at inhibiting nerve pain discharges. There are medications that decrease the central, and those are things like Neurontin and amitriptyline, and there are a few others that to some extent, perhaps Topamax. There are things that decrease the central experience of pain, again, like gabapentin and amitriptyline, and then some of the antidepressants, even if mood isn't involved, will deactivate that central pain experience. And then there are things that help with sleep, like melatonin, and some of the other medications mentioned have an influence on sleep. Typically, medication-wise, in most patients, we start here, but we monitor mood, because if when headaches improve, a lot of times mood falls into place, but sometimes it really does have to be addressed separately if it's been persistent enough, or if it's obviously a factor. The non-medication strategies, we address these other things. This is the first time I've ever presented this information, by the way. So sorry, you're the guinea pigs here. The mood should be in red, because mood is certainly addressable through non-medication strategies with counseling and behavioral therapy and that kind of thing. You have to have a good activity plan. You have to make sure that people don't overdo it right from the get-go, because people have a good day, they overdo it, and then they're in bed for 6 days afterwards. And so you have to really try to have a graded, gradual increase in activity to help build endorphins and help reduce your brain's pain experience. You have to have a good sleep plan. You can't fall asleep with Netflix, and it's just not a good plan. Make sure media is turned off, an hour before bedtime. Make sure there's no vigorous physical exercise 1 to 2 hours before bedtime. If you're taking melatonin, make sure you take it an hour or 2 before bedtime, that kind of thing. And try to have a nice, quiet environment, the typical sleep hygiene stuff. Muscle tension. There are many things that reduce, massage, chiropractic, physical therapy, acupuncture, acupressure, and people rattle around with these therapies. And whatever feels good, I always tell people whatever feels good is good. If somebody tells you it's going to take 6 sessions and it can be a lot worse before it's better, I'd probably try to find something that works in the short run. Because in my experience, the people who really benefit from those therapies, they usually know it pretty soon. I use those as a bridge, though. Those are manipulative therapies, and I use them as a bridge to self-regulation techniques. My goal is to get somebody independent out of my office, out of the chiropractor's office, out of the physical therapist's office, and to be able to do it on their own. And I think that things like yoga, things like muscle relaxation and biofeedback techniques are things that you can do yourself, and they're once you learn the skill, you can do them by yourself. You don't need a copay. You don't have to drive somewhere, and you have your therapist in your pocket. And so that's always a good thing, and that's good for stress management techniques too. So that's the non-medication strategies. The school plan is challenging. I always tell kids that there are two bad pieces of bad news that I have for you. One is that you're going to look better before you feel better, and you don't care how you look, you just want to feel better. The other one is the school plan is kind of tough because you don't want your kid sitting in a noisy band class with a 10 out of 10 headache. I mean, that's brutal. But for all of the reasons, the school absence really exacerbates everything, and so it makes sleep worse, it makes stress worse. Oops, sorry, and you get behind. I've seen people miss grades because of this, and so what I've done, and it's about the only school plan that I've seen that works in my opinion, and if anybody has a better idea, please tell me, because I'm open to it, is I write a school note to the nurse saying they're going to be in the building, but it's absolutely the person's choice to participate in activities as they feel able, or to lay in the nurse's office, sit in the library, do something, and do their biofeedback exercises or whatever we've given them as they feel necessary. It takes parents out of the loop of feeling like you're punishing your kid for having a headache and getting him up in the morning, and you're just sentencing them to a trip in the car to the building. That's it. They don't have to do anything. And in my experience, once you can make that step, I've never seen somebody sit in the nurse's office for a week, even though they've been out of school for 3 months. I've just never seen it. And they're usually fully participating within a couple of days. And it's just, it does so many things. It gets you less behind. Even if you can participate an hour a day, you're not getting as far behind as if you're home all day. You don't sleep in. So the sleep cycle's better. You're more actively involved and engaged. Your mood's probably going to be better. And your brain doesn't learn that I have to be home in my bed in order for this pain cycle to end. You can end it in a more provocative environment. And so those are all the reasons I have, but please inform me if you have a better plan. I see these plans, well, you're going to go 2 hours every other Wednesday, and we're going to get your feet wet, and that's just torture. And in my estimation, it prolongs suffering. And so that's the keys to recovery that my patients have informed me about. Use medication strategies and non-medication strategies to break the chronic pain cycle. Continue non-medication strategies to maintain function and pain control. Other keys to recovery, good sleep hygiene, a good activity plan, a consistent school plan, as I mentioned. The two main reasons why people don't get better in my practice are if their mood's shot and it's not being addressed, or if the school plan isn't being enforced. I've gone through 5 or 6 different medications on a kid, and finally they're better, and talking to the mom saying, boy, that was rough. We finally got there, and the mom will confess, well, yeah, I wasn't sending them to school like I was telling you. So people know that it's that school plan can really be an essential ingredient for some people, not for everybody. The monitor mood and treat as necessary, self-regulation exercises. Additional pitfalls. School plan, first day flare-up. A lot of people say it's never been that bad, right? Because you're used to laying in your bed when you feel awful, and somebody's asking you to get up. It's going to be worse, and a lot of parents don't have the heart to initiate the plan that I know only from experience that will work. But that's easy for me to say. I don't have to deal with your 15-year-old that's yelling at you. The function versus report is another pitfall. A lot of times I've seen people, they say, oh, we tried that and that and that and that. And I say, well, let's try this again, but with the idea of you're going to monitor function versus what your kid is reporting. And I make sure I have that conversation. That's not invalidation. That's just observation that kids, usually their function improves before their report of pain goes down. And if we just listen to the report of pain, we're misled into thinking that things that might be having an effect and will work over time are not working. And I've seen that time and time again. There's an additional couple of observations that don't really fit anywhere, so I put them here. When I talk to kids who've struggled with chronic pain, I think how our bodies work in general, and again, this is assuming your shunt's okay, right? But how our bodies work in general has to do with two factors. It's who we are and where we are. And so if who we are is somebody who needs a fair amount of control, somebody who doesn't like bright lights and loud noises, and somebody who is uncomfortable in certain environments and is control oriented. And a lot of kids with pain, a lot of people with chronic pain have more of a control orientation. They're more comfortable controlling things than being pushed around. And if your world in the 11th grade involves people telling you what to do, here's what time you wake up, here's when you go to bed, here's the stinky kid you're sitting next to in math class, and here's a pop quiz, that's a mismatch, and that tightens a lot of people up, and that really either creates or exacerbates the pain experience. And I've seen time and time again, kids go off to college, and if they're heading in that direction, and they get better. And I used to think, oh, it must have been some family dynamic, but it's whether they go off to college or whether they stay home and go to college. And college is so different from high school in the school-age population. You're doing it for yourself rather than checking off arbitrary boxes to get someplace. And so I've seen that a lot, that it's who the person is plus where they are, and if they're in an environment that is more their style and more what their choice is. And that's why choice is a big thing for folks with pain, because lack of options, lack of choice really hurts. Then there can be some hidden exacerbating dynamics that you got to look for. I remember a kid who he had a concussion and he had a chronic daily headache, and it just wouldn't get better until I took him off the football team. And it turns out he was just terrified to go back to the football team. And he wasn't making up his pain. It just wouldn't get better until his doctor told him that you just can't go back. And I sensed that might be the case because he had gotten sacked like 30 times in a single game, and so that was a clue that I should have picked up on earlier. And so there can be some hidden dynamics that you have to look for. Is a kid getting bullied at school? Are there other factors? Plan B. Sometimes you're stuck, and boy, people aren't budging, and the person's giving you these kind of in-between clues. And sometimes they do, like Dr. Partington said, when all else fails, well, you take the shunt apart. You don't want to. Unfortunately, there are better mechanisms to probably try to figure out if a shunt is working or assure that it's working that will help us with time. Homeschooling, because a lot of times these things can be exacerbated by the school experience, and sometimes homeschooling, I really don't advocate for it, but sometimes it works. I like to keep kids in the mix as much as possible, but sometimes getting out of that inflammatory environment can be good. Chronic pain programs. I can sit and talk about this stuff, but it's not easy to do all of that in the context of an outpatient practice, and you send people to this therapist, and you do this, and you do that. But there are programs. Currently, one of my favorites is the Mayo Clinic has a pediatric chronic pain program, and it works. I'm impressed with how good they are. Even though they're not one of the sponsors here, I guess I shouldn't have said that. And then again, considering possible complex dynamics, just looking around and making sure if somebody isn't getting better, is there something else going on? And that's all I got. I hope that makes sense. Anybody? Oh, yes. Yeah, I know, and the if you look at the statistics, I mean, the just chronic pain with and without shunts is just a huge problem in this country, and and congratulations for staying off of, for attempting to stay off of narcotics, because it's an easy. I think that physicians who are I think physicians tie into the problem of making things worse rather than better, because there are some things that some people have short-term benefit from that, in my opinion, never work in the long run, but create another problem. And you've done if you've been able to with all that horrible experience, stay off, that's...
That seems to be the only thing that I respond to.
Mm-hmm.
So if it is the only thing that I respond to, and I have to just accept the fact that I have to take opiates every day,
Right.
that just sucks. But
Mm.
maybe other options. You do what you got to do with it.
Yeah, I think that in the, again, and I have you look a couple years older than 18. I don't know and so I apologize for not being an expert in your age group, because things are different with kids. We have different, they just are. But typically, my adult colleagues would recommend some sort of chronic pain program to see if there's any way to control pain with less burden, with less burden of side effect, and because you say, you're happy, but you hurt all the time, and so a lot of times those programs can work. But my goal in pediatrics is to keep kids from turning into an adult with chronic pain, because it is a harder thing to treat, because your life is pretty much established, and so there are very few. It gives you fewer options, I think. So I wish I could be helpful. I know that that people.
I went through the amitriptyline, dopamine, all those things, and that made nothing they either made it worse, or jump off a bridge, or whatever.
Yeah.
And then it's like, I don't want to take opiates, because it's freaking opiate epidemic in this country. But when you take one and you can go 3 days to function, that sucks.
Yeah. Yeah.
And then everybody goes, well, that's not the answer. Well, when you go out on a day like tell me what the answer is.
Yeah.
What I mean? But,
Yeah.
I just don't know what's in the pipeline.
Yeah. I'm sorry, I can't be very helpful. Go ahead.
Can I just ask you your thoughts on chronic pain and nausea? My daughter has
Yeah.
chronic pain every day, 14 years.
Yep.
She's starting Zofran
Yep.
3 times a day for the past 10 years. So
Yeah. Yeah.
she still has nausea
Yeah.
all the time.
Yep. I think that this activation of the sensory experience is true of dizziness, it's true of nausea, it's true of numbness and tingling. Those are all sensations that can be activated, and I think it's the same thing. And generally the strategies that work when you get success, and we're not successful with everybody, generally work for the nausea too. And it's just trying to deactivate that nervous system. And if you have a shunt in your head, it's very challenging. When I have that mosquito experience like that I described, I can go inside and I don't think consciously, oh, there are no mosquitoes in here, therefore I don't itch or crawl anymore. But it happens instantly because my brain just does that for me. And in this case, your brain is doing it to you, the fact that you have a shunt. And in my population of kids, it's a reverberating circuit, because it doesn't only do that to the kid, it does that to the mom and the dad, right? You get enhanced vigilance, and the enhanced vigilance affects the kid, and the kid, so those are other dynamics that really influence how difficult and challenging it can be to treat chronic pain. I think that many kids with chronic pain, in my experience, have parents with chronic pain, and it might be a different variety, and people will say, yeah, I have chronic pain, but that's an injury, right? Well, it's the same thing. Some people can break their backs and be fine, and other people, their brains go into these chronic pain cycles that they can't turn off. And so sometimes people can get insight from other relatives who've had a similar path, and I've found that if people say, oh yeah, I tried that and it was horrible, but I tried this and it worked, usually that's a good indicator of something that might be helpful, And so, oh yes.
Question about hydrocephalus and feeling it's not so much a headache
Yeah, I think that it's all, I mean, the way, and again, there's no proof of anything that I presented today. This isn't science. This is me putting together a construct that seems to make sense to me anyway, seeing the patients that I've seen. I tie that all together, and a lot of people, they're hitting the head here about, 10 years ago, and their pain is still right there. And so I think that's the brain just hones in on that sensation. And a lot of people say, it doesn't really hurt, I just get this pressure. I get this pressure sensation, it's right over here, and they just can't turn it off once it's activated. And I think that what it is that the mosquito can leave, but the sensation is still there. And in this case, the shunt can be fixed as best we can assess, and there are different sensations that are triggered. It might have been a migraine that set up that pattern, kind of like the boat ride that never ends. And so I think that certain people are prone to those sensory experiences. And there are two aspects. One is I do see a fair number of kids that we go around and around making sure everything's okay. And when you look at the kid, they say, well, it doesn't bother me, it's just there. In which case, then I just monitor and safely ignore it, right? And it sounds like, well, it shouldn't be that way. But for some people, that's how they live. It feels a little number on this side than this side, or that kind of thing. And we're not very good at fixing every sensory experience, but we're usually pretty good at figuring out whether it's a sign of danger or not.
It's very obvious to me that it's my baseline.
I'm sorry, that's what?
It's very obvious to me that it's my baseline.
Yeah, right. Yeah. And but some of the same techniques and some of the same thinking when people come in with those sorts of sensory symptoms, they can be, they can get relief. Again, in the pediatric population, I'm sorry that there aren't very many kids in here. So what I'm saying may not be relevant to a lot of you. I'm sorry, yes?
Well, part of the reason there aren't a lot of kids in here is that there's a group right now that is including kids specific. So
Okay.
you're competing with that.
Yeah. Never been very good at competing, but.
Yeah. So, I wonder if when we're talking about injury or like sensation of where you were injured before, just having the shunt within your head, just having the device and such, that in itself can just give this chronic sense of like that mosquito where you can
Yeah.
feel that, impact.
Yeah, absolutely, and that's I think the biggest. Again, I've set up the problem. I haven't really set up a great solution. There are things that that I mentioned that can help a good percentage of people, but then you're left with, I'm in a room full of mosquitoes. What if, right? And
It could be sort of like almost like somebody who's had an amputation that fans with chronic pain.
yeah.
I wonder if you could just elaborate just a little bit more on when functioning starts getting better.
Right.
I find I can
Yeah.
say to my son, how's your head? How's your head?
Right, and
Functioning.
yeah, I've had kids tell me, and not just one, but many, when I don't think of it, it's a 0, and when my dad asks me, it's a 4. Okay, and so to me, that's a sign the dad should stop asking, right? Because what you're doing is you're asking them to hone in on that sensation. Something that involuntarily occurs with people with chronic pain is your brain is doing that and you can't turn it off. But once a person gets to a good functional level, I usually stop asking. And the problem is we've made this a bigger and bigger mosquito. It's a big enough mosquito the way it is, but we've made it bigger by the very looking at it, the very monitoring, the very going to the doctor and going to the hospital is an activator. It really is. And so how do we, I think being aware of the dynamics sometimes helps a little bit, right? I've seen MRIs cure headaches before. I'm going to start a medication program, we're going to get an MRI, and the MRI's okay. Yeah, we didn't do the medication, the headaches went away. Because the reassurance of an MRI was enough. The problem with a shunt is, unlikely, but it could be the shunt, right? And that hanging over you is huge. And I think that people have to understand that is not a psychological phenomenon. That is how the brain works. right? Of course, I don't think there is such a thing as psychology. I think that it is simply the phenomena of the brain that we don't understand well and we don't have very good language for. Go ahead. Oh, okay.
So if you have more questions, and if you're willing to stick around afterwards and take more questions.
Okay, one here, and then I'll answer the one who's kind enough to write something down. Yeah.
Since my daughter had her shunts put in,
Uh-huh.
but she also had 3 revisions, and she had 3 craniotomies. She came out with craniotomies, and she had such a high sensory overload,
Yeah.
the smells, touch,
Yep.
movement, and, we prayed a lot, and there's been a big improvement, but it fluctuates, and I don't know if there's a desensitizing that can be done, is there anything? Or there's times where she's, way better, and then there'll be sometimes, especially if she's tired, or I don't know, where it kicks in at a higher level.
Yep.
Explain that?
I think that we have a certain, I think in terms of reserve, I mean, and so sometimes people can just be flying and then their reserve goes away either as a result of fatigue or stress or some other factor that makes everything kind of recur or come back. And I know whenever somebody comes into my office with sunglasses, I always say, ooh, this is bad, because what you're doing is the natural response to sensitivity is to reduce the sensitivity. Well, then you can't function without the sunglasses, and then they get darker and darker, and pretty soon you can't do anything. And so all I can say is I try to gradually push out on the margins with that kind of sensitization, but only gradually. If it's overwhelming, then you have a panic experience, and then every time you go outside, you get panicky, right? Yeah, and so it does have to be a gradual response. The question, if my headache gets better when I lay down for 15 to 30 minutes, is that the best treatment? Are these headaches my normal, or is it a precursor to a future problem? Usually, laying down making a headache better wouldn't be a shunt malfunction. It could be slightly low pressure, but I think that most headaches that get better with laying down for 15 to 30 minutes are muscle tension headaches, and that helps all of us. And I think that is the best treatment, because there's not much that works faster than 15 to 30 minutes. You might consider some preventative measures, like go online and type in on YouTube yoga and headaches, and see if stretching exercises and muscle relaxation exercises can keep you from getting them as frequently. So, sorry we're out of time. Thank you so much for the questions.